everybody. We're back. Hey. It's been 2 years. But we're back.
Oh
2 full years, guys. But the Fresh RN podcast ladies are back.
We're back.
Thank you guys for waiting patiently. We so appreciate that. We're going to do quick life updates and then dive right into this episode. So the main reason that this took 2 years for us to come back is I've had a busy couple years. I may or may not have had a child. That was a big one.
I'm going to go with the May.
That was pretty big. Yeah. And then I got my master's in nursing education.
Wow.
Finished
Congratulations.
that literally 1 week before I had said child.
Wow.
Yeah, that was wild. And then I also, one of the reasons it also has taken so long is I have begun creating online courses. And I love doing that. But it's very labor intensive, a lot of work that goes into that. And I've wanted to put my time into that for a little while, because this is like, the podcast is wonderful, the blog's wonderful, but it's all different pieces. And I wanted to have a place to send people to be like, okay, like if you want to learn how to do neuro or cardiac or a residency, this is me walking you through it in like this one collective way, as opposed to like trying to piece everything together. Right. So I've figured out how to do that, and I've been doing that and getting other people to help me write content where I'm not quite as much of an expert. So that's taken up a lot of time.
I bet.
Yeah.
That's a busy life.
It's busy.
Wow.
And I also have gone full time with doing that. So I work for myself now.
Nice.
Yeah, I worked at it. So while I was doing my master's, I was working PRN on the cardiac med surg unit that I worked on when I first graduated. I was doing that, and then I had my son, and then I was about to come back from maternity leave, and I was like, wait a minute, like I could get a lot more course content done and a lot more blog stuff done and make more money this way. So okay, I'll just
genius.
Right.
Genius.
So for now, I'm not at the bedside, but I'm working diligently to help those that are.
Yep. There's a value to that, though. There's a value to both.
So what have you guys been doing?
You take it away.
Hey, it's Elizabeth. So back in April, I actually left the bedside, and I started a new role as a nurse navigator. I'm still working with the stroke team, stroke patients. And for those who are not familiar with what a nurse navigator is, it's kind of a newer area to go into with nursing. And the purpose of kind of the nurse navigator is you work with patients of a certain population, certain disease process. And you go and you provide them with education and information about, what stroke is, what heart failure is, et cetera. And you follow them along their hospital stay, and you help prepare them for discharge. And, one of the things that we do is we follow up with them when they go home. So we want to make sure they understand medications that they are going to be on, why they're taking them. We also help with scheduling follow-up appointments with our neurology team, our stroke clinic. And it's been very rewarding. It was time for me to kind of move on. I've been at the bedside for, it was 16 years. And it's been a great opportunity. But it's an interesting role. It's definitely one that's growing, and more and more hospitals, I think, will start having these jobs available.
Sounds necessary, because I bet that really provides a different perspective, because in that like neuro ICU or the ICU, it's like I see this very specific snapshot of their stay, and then it's like discharge and going home, and are you following up? Do you know what happened?
Yeah.
Like, and does your family understand?
Yep.
And now that the kind of like trauma of the ICU has passed, although not that it'll go away, but
I mean, we also do some community events, but what we do have is a stroke support group, which my colleague runs once a month. And it's great because we get to see those patients who were in the unit a year ago. Wow. And you see how far they've come. So it's incredibly rewarding.
Man,
it's therapy.
Man, I remember those times that someone would come back like a year later for a follow-up and just come up to the ICU to see us. And oh my gosh, I got emotional sometimes.
Yeah.
Or I wouldn't even recognize them.
Yeah.
Like, I can't believe that you are that person that was intubated and sedated and had the EVD and had the art line and had everything going into you, and now you're walking in here. Yeah. So that's pretty cool to see a full picture. And you said 16 years. This year is going to be my 10-year nursing anniversary. wild.
And it doesn't seem like it goes by
Such
so, it just goes
Yeah.
by so fast.
We're babies. Should we ask Melissa? Do you want to say how many years you've been a nurse, or not so much? You don't have to. It's more than us.
It is more than you. I mean, this year I graduated nursing school in 2000, but I didn't start nursing until 2001.
Okay.
So
okay.
19 years.
19 years.
Approaching
gosh.
19 years. And unlike you two, I'm still actually at the bedside.
Woo, woo, woo.
But I will say it's a much more blended role. So
Yeah, because you're doing some leadership stuff and education stuff all mixed in.
I do. I'm doing, like right now, I'm working on a project to try and help our new nurse preceptors become more proficient and more successful, because we really want our new nurses that are coming into the unit to really be set up for success.
Spoiler alert, we're going to do an episode about preceptors.
But it's been interesting because, the transition to being one of the most experienced nurses on the unit is a different game plan. So
Yeah.
our unit's been through a lot of change, a lot of new doctors, new nurse practitioners, PAs. We've had a lot of new nurses come in with varying experience levels. So really trying to help kind of bridge the gap with all that change and, make sure that we minimize the impact to patient care and really make sure that we allow our patients to be successful in their recovery as best we can. So we're opening up a new neuroscience-based unit. So I'm helping with the training for those nurses and neuroscience training. And so it's been I've done a little bit of everything.
Mm-hmm.
I have done. I think you summed it up really well. I've done bedside. I've done some education. I've done a little leadership here and there.
It is interesting from that perspective of evolving into that most experienced one. Like when I went back to that unit, now I wasn't the most experienced. I think there were a few nurses there that had been there longer than I had, or been nurses longer than I had. But I went from being the 22, 23-year-old new grad, and then I left and I come back, and now I'm like, I'm 32, and there's all these 22-year-olds around.
And they look like babies, don't they?
Like babies. They're all planning weddings and I don't know. It was a different experience to come at it from that, I've been here, been around. I kind of know what to freak out about and what not to freak out about.
Yeah.
And still people kind of learning their own style and everything. That was, I didn't expect that at all. And it's like, whoa, I know things. I don't know. It's just a weird transition. But
I think Melissa Stafford, I was thinking about this the other day. I think, Stafford, you are probably one of two of the best probably nurses in that whole hospital.
Oh, that's so nice.
No,
I cheers to that. I cheers my coffee cup to that.
The value of seasoned nurses who are at the bedside. I mean, you cannot compare. I mean, when you see just nursing turnover in general, as this career is changing, and I mean, and for the patients that are there, I mean, there is you can't put a what am I saying, value or
a price
on. Yeah, thank you. Getting lost in my thoughts. Anyway, you can't explain. I mean, talk or explain how invaluable they are.
I know. I'd let you take care of anyone in my family. It's like, if we have a neuro injury, let's fly Stafford here so she can be the bedside nurse, because oh my gosh. So
you have to be as one of those nurses, you have to be available to help support the team.
Yeah, because so many people look up to those.
I think you're right. I mean, nursing now compared to when I started is very different. So really helping newer nurses kind of come in and get their feet wet and become more comfortable and recognize the responsibility that we have. I mean, it doesn't matter if you're an ICU nurse or a med-surg nurse or an intermediate care nurse or a rehab nurse. There's a value to what you do. And it's really important that you find that, and that you find that the happiness in that value, because it is a tough field. Every day is not fun. There are really tough days, and it really matters kind of how you learn to deal with that over time, because otherwise, you throw your hands up and you're like, I'm done, instead of really figuring out a way to get through those tougher times and to adapt to whatever change is happening around you. Because that's something about medicine. It's always changing.
Yep. It's like jumping on a moving train.
It really is.
You know, and two, I think it's, and I want to just flesh that out just a little bit before we move on to our topic, is that, and I think it's hard for newbies to feel like they do bring something to the table, but I want to make sure that those that are listening know that they do.
Yes, they do.
Even if this is your first day, you still bring value to the table. You know, you can still be a coachable person, someone who expresses gratitude, someone who's going to offer to do things. Like, that's all valuable. Even if you don't know all these complex clinical answers, like, you can still be a valuable member of the team as you learn how to function within it.
Yep.
And it's not like you're a burden. And I'm sure there are nurses out there right now that need to know that they are not a burden.
No.
And you are not a burden.
You are not a burden.
You are an asset.
That is exactly right.
And, you know, there's you and your employer need to or your team kind of invest in one another to make those, whatever values that, I don't want to say values, whatever strengths you have that are yet to be developed, like, work on those. But from day one, you bring value.
Yep.
And I think it's really important that people remember that.
Yes.
There's nothing better sometimes than seeing a new RN who is excited and ready, eager, you know, to get their feet wet and
really engaged.
Really engaged. And that's the big thing, is engagement.
Yeah, because you can't teach that.
No.
You can't cultivate that in someone. They have to that's what they bring to the table. The fact that they care, they want to get better, and they want to, you know what I mean?
Mm-hmm.
So,
yeah.
All right, team. Let's talk about our topic for today.
Let's do it.
When should nurses call rapid response? All right. So first we're going to define rapid response, because I'm sure some hospitals may have a different kind of word or verbiage for this team. But we actually have a former rapid response nurse on this podcast.
Elizabeth.
For those of you that did not know, Elizabeth worked rapid response at a large hospital.
Mm-hmm.
So how about you go ahead and define it?
So the purpose of the rapid response team is to help recognize patients who could be in potential distress or risk for decline, and help facilitate interventions to either help prevent that from happening, or if they need to get to a higher level of care, they help get those patients transferred. Different hospitals have their rapid response teams consist of different members. In some institutions, rapid response team will consist of a APP, or a nurse practitioner or PA, that responds to calls. In the hospitals that I've worked at, most of the time it is a critical care experienced RN and a respiratory therapist. And they have a set of protocols that they follow. And, you know, if patients need to get shipped out of whatever unit into the ICU, they basically help make that happen. They're essential in helping reduce code blues, mortality in the hospital. And I mean, there's tons of documentation to support that. But kind of knowing as a nurse in any part of the hospital, kind of knowing when to call and when it's appropriate is important to know.
Yeah, and I know there is definitely, and I felt this, a hesitancy of, when should I sound the alarm? Because when you do call, it's called overhead, and that team has to respond promptly. So my experience at another hospital, same thing. It was typically an experienced ICU nurse with a respiratory therapist, and actually it's a teaching hospital, so they would have a team, one of the teams that would rotate. So, and it would, you know, the resident, chief resident, and then the first, second, third, you know, the intern, everybody would come, and then they would all kind of go through the situation with the nurse. So let's say your patient's deteriorating, you call a rapid response, these people show up, and you as the primary nurse say, this is what happened and this is why I'm calling. And then together figure out what's the best thing. Sometimes the best thing is getting some other orders in place and they stay on the unit and everything's okay and we just need to watch something else or monitor for something. Or sometimes it's, let's transfer to a higher level of care.
Yeah.
So that's kind of how that practically looks at the bedside. But one of the things is that one of the reasons I wanted to have this episode is because I notice, especially in the med-surg kind of level of care, a hesitancy to call because they don't want to call if it's not a big deal, and then they don't want people to think they're stupid because they called for something that didn't that didn't really necessitate a call. So I wanted to ask you guys, what are like some examples that you guys responded and you were like, man, that nurse made a really good call. Like that was the perfect time to call rapid response.
Yeah, I mean, I think the key is, and where the most success happens is when a nurse can recognize signs of decline early, before it becomes an emergency. So you don't want to be calling right before your patient's getting ready to code. Hopefully you can catch it before that. I mean, sometimes you can't, but you know, when you're noticing a change in the patient's requiring more and more oxygen, or the heart rate continues to increase. You know, if you have a patient who's been flying on 2 liters for 3 days and now all of a sudden they're on 6 liters and struggling, that's an issue. Why is that? Have we investigated that? And, you know, sometimes it's possible for the nurses to have a conversation with the provider on the front end, but sometimes they may not see the provider, and or they don't know necessarily how to advocate to do a better research. Maybe it's been 3 days since the patient had a chest x-ray and we need to check another one.
And they don't know to necessarily dive into that.
Right.
But that experienced nurse coming in would.
Right. And they don't know what labs that might help them figure that out. You know, maybe their kidney function is declining, so they're not able to filter out their water content essentially, so they get backed up that way, or something like that. So I mean, although I've not really gone on a whole lot of like medical rapid response calls, I've been what's considered a neuro response nurse, and I can speak to a nurse that was on an intermediate floor that called, and the reason was because the patient had a history of a stroke and had some deficits related to that stroke. She had some, I think it was right-sided weakness, so let's say right-sided weakness and some slurred speech, but she was able to get up and ambulate. She was able to talk to her family. And for whatever reason, as that nurse came on in the afternoon, the patient really wasn't talking to their family anymore. And that was unusual because it was a very tight-knit family, and they had all kinds of laughs, and, big party in the room essentially was kind of the norm. And that wasn't happening. And it just rubbed her the wrong way. And she made a call, which then was a call to us to come and evaluate. So when I got there, she's right. The patient wasn't able to talk. The patient was not able to follow commands the same as they were before. Still weak on that side, but wasn't responding the same way.
Subtle differences.
Good call. And so, really complimenting that nurse. And she was very overwhelmed because neuro was not her specialty.
Yeah.
But making sure she understands she did the right thing. The patient wasn't responding the same way. And even if you don't necessarily understand what's happening, there's a value in getting another expert there to evaluate. So ultimately, they ended up having a APP comes, nurse practitioner that specializes in neurology, came to the floor. We did a CAT scan, MRI, and the patient ended up being able to stay. But it could have very well gone the other way.
Yeah. And then when that goes the other way, it's not like you can just get that back.
Right.
Yeah.
Right. So this patient actually had neuro changes related to a worsening infection, which can sometimes impact the neuro exam. So turns out there was a UTI. She was starting to become uroseptic. Wasn't to the point where her pressure had dropped or her heart rate was super high yet. But in looking at all the labs and the x-rays and, we were able to figure out that that's what was going on and start her on antibiotics, and let's see. And by the next day, she was kind of back to where she was before.
So the point that I think is really important to know from that is she didn't have to know exactly what was going on, but she knew something was wrong.
Right.
And she needed to get another set of eyes there, right? Yeah. You recognize the ceiling of your knowledge at this point, your capacity to understand what's going on. Okay, I don't know exactly what's going on, but homegirl's not the same.
Right.
We need to get someone else in and then bring more people in. Because I think nurses think they have to figure out the whole clinical picture and then call the physician and then articulate it perfectly.
Right.
And it's like, wait, no. And I think that too, when they're learning EKGs and stuff, it's like, no, day one, new nurse shouldn't be able to interpret a 12 lead perfectly. You need to know when something's wrong.
Right.
And call. And then you can figure out, there's important ones to know, but you don't need to know how to do
There's nothing better than a nurse that's trying to learn more.
Yes.
I mean, as an experienced nurse and going to the floor is watching these nurses try and figure it out, and then being able to have, after the fact, after all the craziness is over, this is what you can look at. These are how you can use these labs. This is some of the information that you can gather from the chart. And then next time, it becomes easier for them.
Yeah.
Exactly.
And they might recognize it a little sooner, and they, may be more comfortable interacting with a provider if one's available. But, a good response nurse, whether it be a neuro response nurse or a medical ICU, PCAT nurse or rapid response nurse or whatever your facility calls them, will use that as a teaching opportunity for a nurse.
Yeah. Not
And
a time
should.
to like bully or like,
No.
how dare you? Yeah.
No.
And if a nurse is getting that from the rapid response crew, then that needs to go up the chain, because that's not, I know good. I mean, rapid response nurses, a rapid response team needs to be able to have a good rapport and keep the trust and lines of communication open. And
because that's when people don't want to call.
That's right.
Even
They're
when
scared.
they need to, because they're gonna have somebody be all judgmental and rude and like, and it's really hard as a new nurse to put that aside, because those are also the highly experienced nurses that you genuinely want to impress, and you want them to think that you know what you're talking about. So it's such a big hesitancy, I think, to like call when you're not 100% sure. So that's a good point. Should go up the chain of command.
There's nothing wrong with saying, look, I'm concerned about this, and this is what I see. And if the rapid response nurse is tied up with something else, she's like, or he or she can be like, okay, I'll come take a look, But I think it's important for nurses to be able to use that resource and know and be on the, safe side of what's going on. And, it's hard because patients, even providers, can't figure out what's going on with a patient for a while.
Yeah.
I mean, it's not black and white. It's educated guesses and let's see. And, unfortunately, that's just how it is. So, even if you're concerned about a patient, one day and you're like, something's not right, there really may be something that's not going right. And it may not be until 2 days later where, unfortunately, something, goes on.
Yeah.
And I know as rapid response nurses, like we would, if there was a patient that a nurse was concerned about, we would go check it out. And, maybe it's like, well, let's just kind of see, how this plays out. I know we would always follow up with those patients just to see how they're doing. Because, things can change later down the road. So just having rapid response on the radar about a patient is a really good idea.
They do. I mean, like in our facility, the rapid response nurses will follow up with those patients, like you said, somebody called about it on Monday, so I'm just going to keep an eye on things, and nothing's crazy going on right now, but let me just peek at the labs and see how they look today and whatnot. And I think it's great. I mean, ultimately, remember, this is patient safety. So regardless of whether or not you have a knowledge gap or not, you're looking out for the patient and you're advocating for the patient. So the rapid response team is a really valuable resource to teach you ways to do that.
All right, guys, we're going to take a quick break, and then we'll get back to some more good times to call and maybe some not so necessary times to call. All right. All right, guys, we're back. One thing I wanted to tell you guys about is a new course that I have coming out. It's called Breakthrough ICU, and it is to help those of you that are new to the ICU environment transition into that stressfulness, instead of really trying to survive through orientation, you're actually thriving. And that's my goal, is that when you finish orientation, that you, while you're not going to know every little thing, you feel confident in your abilities to take safe care of patients. So myself and another ICU nurse who's a nurse educator, it's got, 70 modules, like tons of videos, worksheets, and all that good stuff. So if you head to freshrn.com/courses, you can check it out. And I also have show notes. That is a new thing that we're doing. So we have show notes for all of our episodes already. But if you go to freshrn.com/41, you can find the show notes for this episode. I will have in there an ICU drip chart that you can download and print right away. That's and bring awesome. That to your bedside. And so you can just like reference it really quickly. But before you use it, I want you to double check it with your facilities policies and stuff. I mean, I've updated it, but that stuff changes all the time. But print it off, then you can bring it to the bedside so you can see, wait, what do I start Levo at? Like, wait, what do I start this at? So That is all free for you. So
Sweet.
freshRN.com/41, because this is episode 41. And that's what we're going to do for the rest of our episodes now. So if you need any resources or anything that we talk about, I'm going to put them in there. So it's all in one lovely little place.
That's awesome.
Yay.
Good job.
So let's get back to talking about rapid response NIS. Let's do another episode or another another example of a good call.
So the pulmonary system can be complicated. And most of our calls as rapid response nurses were usually pulmonary related. And I think sometimes that can be something that's easily overlooked.
Mm-hmm. Yeah. Because their respiratory rate's always 18.
Yeah.
No, they throw a 20 in there.
They'll throw a 20.
You get a
There's a
random 20.
But if you actually counted 20 respirations a minute, that's still kind of fast.
It is.
If you're resting, you're really breathing like sometimes 14, 18.
Yeah.
Anyway. But it's not just the O2 saturations that are important with a patient.
That's real. That's so many people get focused on those numbers.
Yes, they do.
Yeah.
Like their oxygen level's 95, but they're actually breathing 45 times a minute.
Yeah.
And they're using their accessory muscles and they look
Yeah.
like they're going to
Right.
die.
So looking at work of breathing, I think is really, really important. That I agree. I don't necessarily think that nurses really pay attention to.
That WOB, guys.
Yeah.
And it's, listening to lung sounds is important. And I mean, you really should listen to your patient's lung sounds when you come on in the beginning of
yeah.
your
In all
shift.
quadrants.
Guys, I had a
Feels.
quick
Yeah.
little story here.
Bro, yeah.
I had a patient, I was just coming on. So, and this was on the, where I had like 5 patients on day shift. And I had just come on. The provider had rounded like at 7:32, And she goes, "Have you listened to his lungs?" It's like, "No, I haven't listened to his lungs." Hi. And then,
Good morning.
morning. And it's a med-surg floor, so you only assess like a full assessment once a shift. So it'd been about probably 12 hours or probably 10 hours since he'd have an assessment. And she was like, "You can't hear any of his lung sounds on this lung." I'm like, and then I go in there like, "Son of a gun, sure can't." Someone's got a little pneumo and we had a little situation on our hands. But yeah, you like have to listen to the lung sounds. I've had instances where it's like, okay, I don't think that was done.
Right.
Bad news bears.
Right.
Yeah, but I interrupted you.
Well, no. Well, I mean, those are 2 key things. So just not looking at their O2 sats. And work of breathing is, I think, one of the telltale signs that a patient is declining. And I know, like, I've read in case studies where, respiratory status starts to decline 8 hours outside of a real big emergency event. So recognizing those symptoms early on can make the difference between, that patient
Code
potentially
blue
coding.
Yes.
Because most code blues are respiratory related.
That's
Hypoxia.
and you think about like I think I used to think that if a patient's gonna, especially the way it's portrayed in nursing school, if a patient's gonna go bad, it's like a light switch. It just happens. But really, it's this slow progression, right? And it's like, okay, I've been here for 6 hours and I assessed that patient earlier, but okay, they were on 2 liters. Now they're on 4 liters.
Yeah.
Now they're on 6 liters
Yeah.
and they're working kind of hard and they are refusing to work with therapy because they're tired. It's like, okay, wait, this patient I'm looking at now is very different from the one I looked at it at 7:30. And it's important sometimes you have to actually pause and think back and compare the two, because so much time goes by and so many things, especially when you have other patients and whatnot. It's like, wait a sec, this is subtle, but these are important changes.
And work of breathing is, it's how deep are they breathing? Is it a deep, or is it very shallow? Because sometimes really shallow breathing is not a good thing.
Yeah.
Because they're not able to take enough air into their lungs. It's about accessory muscle use. So when we say accessory muscle use, that means, are they using their belly to help breathe?
Are you pulling up that gown to look too? Because you can't tell if they're using accessory muscles unless you pull up that gown and you look at their ribs and see if you can see the space in between it when they're inhaling.
They can start to work so hard where they get retractions, where you can literally see the skin skin, like suck in either between the ribs or kind of around your collarbone if they're really working hard. And those are, I mean, that when you get to that point, it's actually late.
Yeah. Yeah.
But, you know, you really look at what is the quality? Is it a nice, normal, deep breath? Are they able to say a full sentence when they're speaking to you? Or do they have to take 2 or 3 breaths in order to finish? I mean, if I'm up and I'm walking around and, you know, I'm working out, you know, that's one thing. But if I'm just getting up and moving from the chair to the bed and I can't breathe through that, that's a problem. So, you know, we have to watch those signs, and you have to watch to make sure that, are they really, I'm trying to think of how I want to articulate that, but, you know, can they sit up and breathe? Can they lay down and breathe? Or are they no longer able to lay flat? Do they have to have their head of bed elevated because they can't catch their breaths? You know, someone who's heavy and has a large abdominal girth, it's very common for them not to be able to lay flat. So being able to catch a difference in, could they recline 45 degrees before and now they can't, is different for that particular patient. So it's really important.
You know, that reminds me of, actually, this reminds me of the very first rapid response I ever saw back in 10 years ago. Yeah. But I remember my patient, she had her O2 sat was fine. I actually don't even remember what was going on with her, but I remember her O2 sat was fine. And the surgeons were coming by. She was a pulmonary patient. And I can't remember why she was there, but surgery was coming by for some reason. And I remember the surgeon standing at the edge of the bed saying, well, she's not going to last long breathing like that. You're going to need to tube her soon. And to me, I was like, oh my God. Because I was like, intubation. Like, oh my God. I didn't know that. Like,
yeah.
I got very, you know, I'm med-surg, brand new, intubating people. That is terrifying.
It's not what I do.
And I also wasn't even thinking that. And it's like, but then she was working really hard. And I didn't notice.
Yeah.
And I felt terrible that I didn't notice that she's actually kind of working pretty hard to breathe. And yeah, her O2 sat's fine, but she can only compensate like that for so long.
That's what it is.
And when
compensating.
and then that, like, when they stop compensating, that changes very, very quickly.
Well, and it's also what that little finger probe tells you their oxygen saturation is not what their partial pressure of oxygen is in their blood. So you can have a normal SpO2, which is what most of us read. But if you actually did a blood gas and looked at their oxygen level and their arterial supply, it could look very different. So that's the reason why they don't necessarily go off of what the stats say. Like let's check an ABG. Let's see what the oxygen level is. Let's see what the carbon dioxide level is. Because don't forget, carbon dioxide drives most of us to breathe.
Yeah.
So
that's a good point.
Oh, ABG.
Maybe your
patient's
okay,
not breathing enough. Should be, 5 breaths a minute. No. That's you need to call.
That's a problem. Yeah, no, yeah, like you have to assess further with an ABG, and a lot of times, a lot of these rapid response teams have those protocols, and actually, a lot of hospitals will have like an admission order set where there's a standing order if they're having respiratory changes that you can just go ahead and get an ABG, right? I remember that. I don't want to check your orders first, but that's a wise thing to do is to get an ABG and check.
Yeah.
So good times to call are respiratory decline, and even if it doesn't need to be an emergency, it can be, hey,
there's changes.
We're working harder to meet the same level
demand.
So let's switch gears here. What would be some possibly unnecessary times to call? Like maybe you guys got called and then you go and you're like, well, they probably could have handled this independently. Well, I know that's a teaching moment. I want to use this as a teaching opportunity to say, hey, but caveat, if you think you need to call.
Yes. I mean, I think never forget that hypoglycemia can be tricky. So you have a blood sugar that's less than 70, then you can get stroke-like symptoms, for example. So when you see a patient who's having those changes, don't underestimate the value of doing a blood sugar check. Because a lot of facilities either have standing orders or some sort of protocol in place that allows you to treat that low blood sugar pretty quickly.
Yes.
Because if you get hypoglycemic, you can it can really change your hospital course depending on the severity of it. So it's important that we address it pretty quickly. And that's not necessarily a rapid response call. If they're having stroke symptoms, they're on the side of caution. Don't get me wrong. But, when you come across a patient with a low blood sugar, make sure that you're following the orders that are available to you.
Yeah.
If they're not responding well.
Yeah. I've seen, and actually, I think I remember the first few years of my career, like, oh my gosh, they're hypoglycemic and very symptomatic, and on night shift, responsible for it by yourself, like very intimidating. But yeah, a lot of times you do have those protocols, and even if they are not able to swallow, there's, you get the IV stuff, and they should perk back up, and you follow the protocol. But yeah, I've seen rapid response called in that, and it's probably like, all right, you can handle that independently, although it can be a little shocking at first, but that's definitely something you can handle yourself.
And again, a good rapid response nurse will say, remember this order set. Maybe they didn't know how to put the order set in.
Yes.
Maybe they didn't know that was within their scope.
Right.
Maybe they didn't follow the follow-up blood sugar. So maybe their blood sugar, instead of going from 50 to 250, only went from 50 to 120. And so they were hypoglycemic again in 10 minutes. So, there's a lot of things that can happen with that. Always err on the side of caution. But just think through what resources that you have that are already in place.
Yeah. Yeah. I think
AFib can be tricky too.
Yes.
Because it's a rhythm change. Maybe the patient's in and out of AFib and the nurse didn't know that. AFib can be hard because I know, AFib, your rate can go from 70 to 130, then back to 90. It can be all over the place.
Yeah, or sustained
and it's
at
so important to
170.
see how a patient feels.
Yeah. Symptomatic.
Do they even feel it going on? Are they like, yeah, I feel really dizzy, or my heart feels like it's racing? Is their blood pressure low? When you make a rapid response call, it is important, one, to stay with that patient when rapid response gets there, because they're going to be asking you questions, and to get your vital signs, get a vital sign and blood sugar.
I think it's really important. Yeah. Like, especially if you're incredibly busy on the floor.
Yeah.
If you have an issue with your patient and you call rapid response, when they show up, it's not like, okay, they've got it. Like, you need to be in there with the provider that's come to the bedside, and then anyone else that's there to help facilitate what's going on. Like, that's not
because you're their storyteller.
Yes. And then you can facilitate things and help get whatever the patient needs. It's not a time for you to think that they've got it taken care of. And that reminded me of another
Documentation of all this too, guys.
Oh, yes. Afterwards, you're making sure, especially if the patient's getting transferred to a higher level of care, like, we've got to really know what necessitated the call, what changed, what orders were implemented.
That's probably, I used to be a nurse peer review, and I was chair of a committee for a long time. And that was one of the frustrating things that I came across a lot, is that nurses would call rapid response. But if you read the charting, the patient was fine. There was never any documentation on what led up to respiratory distress, or what led up to rapid response, because clearly something was going on.
Yeah.
And I'm glad that they recognized they needed to call. 100% glad they recognized it. But really kind of paint that picture on what's going on leading up to, why are you concerned? Make sure that you reflect that concern in your charting.
And that's not punitive. It's just like,
No,
we're
not at all.
storytellers.
Yes.
That we have to be able to, like, say what happened, and that's so crucial as a part of, like, your role as the primary nurse. Another thing too that I wanted to mention earlier, but I didn't. I've had times where, another time that is a good idea to call is if you're not getting prompt response from a provider
Yes.
when the patient's deteriorating. So I had that happen once, and that was one of my early rapid response calls, where I had a team of residents. I was on night shift. The guy's declining slowly. It's not in a sudden code or anything, but it's like, I'm concerned, and we ran this and we did this, but and I asked the other nurses, and they were like, yeah, I think I'd call one too if it was me, the experienced nurse. So I did, and he was septic and got transferred to the ICU and died the next day. Not that I don't, like, if I would have done it an hour or two earlier, don't think that would have changed things, but it was just like, and the doctor that came, who is a different person, obviously, than who I had been talking to, I'm explaining things to him, and it's like, okay, this, like, the stuff that you were saying earlier, they probably should have come and looked at the patient, like things like that to consider too. Like, sometimes you need decisions made very quickly.
Yeah.
And having a rapid response team there facilitates that exponentially than paging, waiting for the call back. and then putting in the orders. And you know what I mean?
Yep.
So it's important, if you're not getting the response that you need, that's another time that's
They
appropriate
can
to call.
absolutely help advocate with a provider.
Yeah.
I've
Yeah.
seen many rapid response nurses help with that. And, I've seen them have trouble with some providers too.
Yeah.
Like
Yeah.
really trying to advocate for a patient. I need to check this. I need to check that. And thankfully, because of those order sets, it makes it easier for them. So they can revert to the order sets.
Mm-hmm.
But ultimately, if your rapid response team is a registered nurse, not an advanced practice provider of some sort, they have to abide by their scope of practice too.
Yeah.
Yep.
So they have to make sure that they're following their orders and their protocols the same as a bedside nurse would.
I mean, there have been situations where doctors or providers have not returned calls, and it's bad enough, and the rapid response nurse just calls the intensivist and says, "Hey, this patient needs to get here."
Yeah. And then, and then that
and
intensivist can have a conversation with that one that's not responding.
Yeah.
And that's out of because it's like, I shouldn't be dealing with that.
I think
At all.
nurses need to know they do have support, and they have a way, if they're not getting what they need, there are other avenues to take, hence calling rapid response, or, that's a whole nother
Oh, yeah.
episode.
I may or may not talk about that in Breakthrough ICU. Just say it. It's in there, guys.
Yeah.
Check it out. Okay. So I think that kind of rounds out our episode. Big picture, rapid response is there to help you facilitate clinical decision making when a patient's deteriorating. It is highly recommended to call when you're concerned about anything. It's always better to call and be wrong than to not call and have a code or have a patient have a poor outcome.
And it's not, and I don't think it's necessarily always wrong, but just to say, I have a concern.
Mm-hmm.
And there should be, hopefully your institution has a rapid response policy that actually gives criteria on.
Oh, that would be a really great idea, to print that bad boy out and just take a look
appropriate.
at it.
Mhm.
Yeah.
Put that on your little clipboard with your ICU drip chart.
It can be a little
One on
broad,
top
but
of the other.
there's nothing wrong with
Always
saying,
err on the side of caution.
Yeah, absolutely. And you know what? If you get a little snarky nurse that's like trying to be condescending, my encouragement is to try to turn it into a teaching moment where it's like, I seem to have upset you. Is there something I did? I'm in a learning mode, and I would really like to know what you're picking up on that I clearly didn't.
And let me just kind of play devil's advocate. If you have a patient who is deteriorating and rapid response is there, if they're like demanding and a little snarky in the middle of this urgent situation, please do not take it personally.
Yeah.
They are under stress. They know this patient's getting ready to go downhill. And, if they sound demanding, just work with it. Just work with it. I would get that way sometimes, but I would always come back and be like, hey, I'm sorry, but this stuff had to get done. So
Yeah, because you do have typically ICU nurses are the like very
Intense.
assertive,
Yeah.
and have to get things done very quickly, which is the nature of that environment.
Yeah.
Darn, it's in that Breakthrough ICU again.
Okay.
But it's that's an assertive kind of thing. Hopefully, if a nurse is being very assertive with you, that they're going to follow back up and say, hey, that was the nature of that situation. Hopefully they do that.
Yeah,
I'm sure
they
some
should.
out there are very straightforward and don't follow up. And so if that happens, I don't want that to like break your stride, man. You did the right thing you needed to
Yeah.
for your patient.
Yeah.
And that's what matters at the end of
That's
the
right.
day.
That's exactly right.
So that concludes our episode, y'all. Thank you for listening. We're back, and it's wonderful.
Yay.
Yay!
I would love for you guys to go to freshrn.com/41 to check out our show notes, any other resources about rapid response, that ICU drip chart, and subscribe to you can subscribe to my email list, but then also we would love comments and ratings on this show, and that helps us make it better and also gives us ideas for more episodes. So thanks, nurses. Stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you scream.